Hi friends, today I am going to talk about edema. First is the disclaimer. This video is made for educational purpose only and information given here is not to be used as an alternative to a healthcare professional's diagnosis and treatment. There is no endorsement for any brand or the company. It has been seen that the patients who are suffering from hypertension and type 2 diabetes and if their age is above 50 years of age, 41% these patients have pedal edema, that is swelling in the feet or lower limbs. And if these cases are left undiagnosed, it may lead to cardiorenal complications. Edema is abnormal fluid accumulation in the interstitial space that exceeds the capacity of physiological lymphatic drainage. The mechanism of edema formation is, as we know that interstitial fluid space is dependent on the hydrostatic and the oncotic pressure gradient across the capillaries and also the lymphatic drainage. So the four main factors which determines the accumulation of the fluid in the interstitial spaces are capillary permeability, capillary hydrostatic pressure, capillary oncotic pressure, and fourth is the lymphatic drainage. Any dearrangement in these four can lead to increase in the interstitial fluid resulting in the edema. If we see that whenever there is increased hydrostatic capillary pressure, it may be because of venous obstruction, hepatic cirrhosis, heart failure, constrictive pericarditis, restrictive cardiomyopathy, renal failure, pregnancy, then there will be shift of the fluid from the artery or the capillaries to the interstitial spaces. And even if there is effective intravascular volume depletion, that will also lead to the shift of the fluid to the uh, interstitial spaces. And also, when the patient has decreased oncotic pressure may because of malabsorption, nephrotic syndrome, liver failure, malnutrition, this will also lead to the shift of the fluid from the vessels to the interstitial spaces. Even if these factors are not met and whenever there is decreased interstitial hydrostatic pressure in the uh, in between the cells, this will also draw the fluid from the vessels to the interstitial spaces. There are few medications which affect on the lymphatic, which also cause interstitial edema, and whenever there is destruction or obstruction of the lymphatic drainage system, that may lead to interstitial edema, and the lymphatic obstruction is especially seen in filariasis, malignancies which involve lymph node, and posterior post surgery like lymphadenectomy or the patients who are exposed to radiations. There are various causes of edema, and we can categorize them into whether they are because of increased capillary permeability, increased capillary hydrostatic pressure, decreased capillary oncotic pressure, lymphatic obstructions. Like increased capillary permeability is seen in whenever there is local cause can be cellulitis, systemic causes like hypersensitivity reaction like sepsis, hypersensitivity reactions and sepsis. Increased capillary hydrostatic pressure can be because of some local causes like compartment syndrome, chronic venous insufficiency, systemic causes like congestive cardiac failure, renal failure, pulmonary anemia, pregnancy, decreased capillary oncotic pressure. The systemic causes of protein deficiency states like chronic liver diseases, nephrotic syndrome, protein losing enteropathy, malabsorption syndrome, or lymphatic obstruction may leads to this interstitial edema because of filariasis, radiation, trauma, or the tumor. Similarly, depending upon the system involved, we can categorize like some cardiac disorder. This will lead to generalized edema and localized edema. And generalized edema is because of systemic illnesses, and local edema is because of local pathology. In generalized edema, the causes are cardiac, renal, hepatic, and thyroid disorder. Among the cardiac disorder, we must explore the history of some cardiac diseases. Renal disorder like nephrotic syndrome, kidney failure, and hepatic disorders are like hepatitis, history of alcohol abuse, cirrhosis, thyroid disorder, hypothyroidism, thyrotoxicosis. And if the respiratory system is involved, respiratory like patients with COPD, which further land up with the carpulmonale, they can have these generalized edema. Localized edema is seen in cases of DVT, lymphatic obstruction, local infections like cellulitis, dermatitis. There are certain drugs which can cause edema, like direct arterial vasodilators. Nowadays they are used, but these are not first line drugs like hydralazine, clonidine, methyl dopa, alpha blockers. There are some calcium channel blockers like amlodipine, non-steroidal anti-inflammatory drugs like ibuprofen, diclofenac. There are some hormonal preparation like which contains glucocorticoids, anabolic steroid, estrogen, progestin, growth hormones. Oral anti-diabetic drugs like thiazolidine groups, rosiglitazone, pioglitazone, antidepressant like monoamine oxidase inhibitors, they also cause edema. Anasarca is basically a generalized edema because of fluid overload and hypoproteinemia, and there is the effective arterial blood volume is reduced, renal blood flow is decreased, the renin-angiotensin aldosterone system is activated and it causes sodium and water retention. This is usually seen in the patients of those patients who have gross hyponatremia or cardiac failure or some kidney failure. History taking is very important whenever we have to uh, diagnose a case of edema. If the patient has in the history should be taken regarding asking his current illness and the past history. In current illness, we have to ask about the duration of the edema. Is it acute or chronic? Does it improve overnight? Its location, whether it is a unilateral or bilateral. Does it change with the position? And is it associated with other symptoms like dyspnea, oliguria, anuria, fatigue, lethargy, any change in the appetite, history of weight gain or weight loss, any history of fever, pain, whether there is any altered sensorium, whether patient is pregnant or not, especially if the female patient is there, is the menstrual history is proper, uh, does he or she records her weight daily. In the past history, we have to ask about the previous episodes of peripheral edema in the past, history of any other systemic or other disease, history of any cardiac disease like heart failure, myocardial infarction, pericarditis, cardiac surgery, any history of hypertension, hepatic diseases, renal diseases, diabetes, thyroid disease, connective tissue disorders, tuberculosis, any history of malignancy or previous radiation or surgery done, any history of venous incompetence, any addiction to alcohol, smoking, or other substance abuse. We have to ask for or see for the risk factors and the family history, any risk factor for deep vein thrombosis, any history of alcohol consumption, any history of heart failure in the family, any history of medication overuse like calcium channel blockers, vasodilators, non-steroidal anti-inflammatory drugs, corticosteroid, antidepressant, estrogen, progesterone, thiazolidines, and anti-cancer drugs. In history, we have to see the site and the distribution of the edema. whether it is a unilateral or bilateral. In the unilateral pedal edema, local cause can be like deep vein thrombosis, cellulitis, compartment syndrome, filariasis. Bilateral pedal edema, the causes are congestive cardiac failure, anemia, chronic kidney disease, chronic liver disease. Duration of the illness is important. Cellulitis, DVT, compartment syndrome are usually short, they have short duration, and the chronic history is seen with the systemic diseases, hypoproteinemic states, chronic venous insufficiencies, lymphedema, uh, painful edema is seen with DVT, cellulitis, and painless is seen in systemic diseases, hypoproteinemic states, venous insufficiency, lymphedema. We have to see the variability of the edema. Congestive cardiac failure edema that is usually present in the dependent parts, and it is aggravated by the standing and improves overnight with limb elevations. Nephrotic syndrome edema, it is characterized by the generalized but especially evident in the very soft tissues of the eyelid and the face in the morning. Chronic liver diseases like patient can have peripheral edema with ascites also. We have to ask about the systemic illnesses like if the patient have any cardiac involvement, he will have exertional dyspnea, orthopnea, paroxysmal nocturnal dyspnea, chest pain, palpitation, and the patients in whom the renal system is involved, they will have uh, oliguria, that is decreased urine quantity in 24 hours, less than 400 ml, and they will have puffiness or swelling of the eyelids in the morning. The patients with hepatic liver involvement, they will have history of long-term alcohol consumption, any history of blood transfusion, tattooing. They will have other features of jaundice and abdominal distension like ascites. We have to take the history of hypothyroidism, whether they feel fatigue, whether there is any history of weight gain, decreased appetite, sleepiness, cold intolerance, constipation, decreased menses. Obstructive sleep apnea history is very important in these patients, whether they snore at night, whether their sleep is interrupted by the episodes of apnea, whether they have any excessive daytime sleepiness, daytime fatigue or tiredness, any history of drug abuse like calcium channel blockers for hypertension, and whether they are taking any non-steroidal anti-inflammatory drugs or other painkillers for the pain, or whether they have or any steroids. 50% of the patients who are on calcium channel blockers and 5% of the patients who take non-steroidal anti-inflammatory drugs, they have history of pedal edema. We have to elicit the history of any trauma, radiations, and the long-term radiation can cause lymphedema. Coming to the local examination, we have to see the distribution, whether it is unilateral, bilateral, and if it is involving the boning prominences like medial malleolus or anterior aspect of the tibia or the sacrum. It is very common in the sacral region in the bedridden patients. Tenderness is seen in patients of cellulitis, DVT, compartment syndrome. Edema due to lymphedema or other systemic diseases like hypoproteinemic states, cardiac causes. These are painless edemas. Pitting edema is usually all edemas are pitting edema except the edema due to lymphedema or mixed edema. Lymphedema is initially pitting, but later it gets uh, non-pitting because of hyaluronic acid deposition. Sorry, uh, it is because of uh, thickening of the tissues, and in cases of hypothyroidism, there is a deposition of the hyaluronic acid, and which leads to edema in the lower limbs. Skin changes like cellulitis, mixed edema, chronic skin changes in the form of cellulitis, especially in the legs or the upper limbs, can be seen, and the cellulitis area is usually red, hot, and swollen. Mixed edema is dry, coarse, and thick skin is seen over the edema. Patients who have chronic venous insufficiency, they have hemosiderin deposition, which leads to brawny skin, and chronic venous insufficiency is seen in the patients who have varicose vein, or at times they can have venous ulcer also. The chronic lymphedema leads to hyperkeratotic and papillomatous skin with induration, and it is called lymphostatic verrucosis, that is elephantiasis. Kaposi's tremor sign is the inability to pinch the skin on the dorsum of the foot near the second toe. These are the few pictures which show how we see pitting edema. Patients with mixed edema, their presentation, cellulitis, chronic insufficiency, filariasis. How can we grade the edema? By pitch depth. Whenever we at the edema side, we pinch it with a finger. If there is no depression, then we grade it as 0, and if there is 2 mm depression with when we lift up the finger and it disappears, this is grade 1 pitting edema. If there is 2 mm depression and the depression disappears after 10 to 15 seconds, it is grade 2 edema. Grade 3 edema is when there is 6 mm depression on pressing the edema site, and the depression lasts more than 1 minute. And grade 4 is severe pitting edema, means 8 mm depression that lasts for more than 2 minutes. Coming to the systemic examination, the patients with congestive cardiac failure, they will have elevated jugular venous pressure, they will have basal creps, they will have third heart sounds. The patients of chronic liver disease will have icterus, ascites, splenomegaly, gynecomastia, spider nevi, and other features of chronic liver diseases. Patients of chronic kidney disease will have anemia, dry skin, uremic breath, and the patients of hypothyroidism, will have skin changes like dry skin and sparse hair. They will have hoarseness of voice, and they will have ECG changes of bradycardia. This is the picture which depicts the raised GBP. The neck veins are swollen. JVP will be raised in patients who have congestive cardiac failure, carpulmonale or renal failure, and it is not elevated in protein deficient states like cirrhosis, nephrotic syndrome, or malabsorption syndrome. The causes of unilateral edema can be categorized as painful and painless. If we see the onset, if it is congenital, then the maybe because of some anomalous venous connections or Milroy's disease. And if it is acquired, we have to see whether it is because of lymphatic causes or vascular causes. Among the lymphatic causes, there may be because of lymphatic obstruction, post mastectomy, or some malignancy. And if it is because of vesicular vessels involvement, it is because of DVT, varicose vein, or venous insufficiency. The unilateral edemas are usually painful. These are not painless. If it is involves only digits, then it is maybe because of inflammatory arthritis, and some if only one part of the limb is involved, then it may be because of cellulitis, and if it involves whole limb, then we have to see whether it is a pitting or non-pitting. If it is pitting, we have to do well score. If it is low, we have to look for other causes. If it is high, then we should have high suspicion of venous thrombosis. And if it is non-pitting edema and involving the whole limb, then we have to look for filariasis. So the unilateral edemas, they are usually painful. They are not painless. Coming to the bilateral edema can be categorized having edema of feet, depending upon the pitting or non-pitting, associated with ascites, associated with puffy face, with history of weight loss, cachexia or starvation. If bilateral edema is limited to the only feet, then we have to see whether his JVP is raised or not, or it could be a idiopathic cause. If the JVP and the chest sign like basal crepes, if they are absent, then it may be because of nutritional edema, nutritional edema. And if the JVP is raised and the patient have basal crepes or third heart sound, then it may be because of heart failure. And if these this edema is present only in the left limb, then JVP is raised and other chest signs are also there, then we can think of left ventricular failure. If the edema is pitting type in nature, then we have to look for other features like polyarthritis, systemic disorders like cardiac, renal, or hepatic causes. We have to look for other causes of obesity, any history of pregnancy, especially in females. If the bilateral edema is associated with ascites, then we have to look for JVP. If the JVP is raised, patient has hepatosplenomegaly and he has ascites, then the cause could be because of cardiac involvement like pericardial effusion or constrictive pericarditis. And if the patient have bilateral edema with ascites and his JVP is raised, and if he is having splenomegaly, the likely cause is portal hypertension. And if the patient has bilateral edema with ascites and his JVP is raised, he has ascites and has massive edema in the feet, then chances are there that he can have inferior vena cava obstruction. If the patient has edema, bilateral pitting edema or bilateral edema with puffy face, we have to ask for history of any constipation. We have to see rough skin, any history of horseflies, and if these features are met, then she may be having or he or she may be having mixed edema. If the patient has a puffy face and has hypoproteinemia, hyperlipidemia, then the possibility of nephrotic syndrome cannot be ruled out. If the patient has bilateral edema with puffy face, with sudden onset, wheezing, or any itching, then it could be because of angionephrotic edema. If the patient has bilateral edema with puffy face, with history of hypertension, hematuria, proteinuria, then it could be because of nephrotic syndrome. If the patient has bilateral edema with history of weight loss, cachexia, and history of starvation, then it could be because of malnutrition, protein energy malnutrition, kwashiorkor. If the patient has bilateral edema with history of intake of drugs that increases the risk of edema, then we have to stop the drug or replace the prescription whenever possible. If patient has bilateral edema and other causes are not, we are not able to elicit, ask him about any history of diuretic intake, because diuretic induced biliary edema is very common in few cases, and it is called paradoxical edema. These are the few causes of bilateral pituitary edema and approach. In Indian setups, we have whenever a patient of edema presents to us, we have to take the history very carefully. Examination should be given the priorities to reach the subsequent diagnosis. In case of suspicion of DVT, we should always stratify the patient based on the well score. Edema grading scale can help us in differentiating between pitting and non-pitting edema, and it helps in identifying the etiology of the edema. Patient may be given a simple self-evaluation test to evaluate the risk for serious systemic causes in future. The well score for predicting the possibility of DVT involves like history of active cancer, patient either receiving treatment for cancer within the previous 6 months or currently receiving palliative treatment, he is given score 1. History of paresis or recent cast immobilization of the lower extremities, it is given number 1.1. History of recently bedridden for 3 days or major surgery within the previous 12 weeks requiring general or regional anesthesia, again it is given 1 point. Localized tenderness along the distribution of the deep venous system, 1 point is given. Entire leg swelling, 1 point. Calf swelling at least 3 centimeter larger than other asymptomatic site, it is measured just usually below 10 centimeter below the tibial tuberosity, and it is again a given 0.1. Pitting edema confined to the symptomatic leg, 1. Unilateral collateral superficial vein, non-varicose, 1. Previously documented DVT, 1. Alternative diagnosis if at least as likely as DVT, -2. If the well score is -2 to 1, then the DVT is unlikely. If it is -2 to 8, DVT is likely. Or based on the probability, we can, if it is -2 to 0, then the probability is low. -1 to 2, probability is moderate, and -3 to 8, the probability is high. In the lab investigation, we have to do complete blood count to rule out anemia, urine routine and microscopy and renal function test. They will help us in reaching nephrotic syndrome or chronic kidney disease. LFTs are important to rule out liver disease. Serum total protein, albumin, they will help us find out chronic liver disease, nephrotic syndrome, protein losing, enteropathies, malnutrition, serum lipid profile to rule out nephrotic syndrome, coronary artery disease, chest X-ray, ECG and BNP, they will help us reach the heart failure. Serum TSH level to rule out hypothyroidism. D dimers are usually elevated in DVT. If this is not elevated, then DVT is ruled out. Ultrasound abdomen and KUB helps in finding out the liver disease and about the kidney status. Doppler studies help in deep vein thrombosis and chronic venous insufficiency. Lymphoscintigraphy, it is help in detecting any lymphatic disorders. Here the radionucleotide tracer is injected in the first web space and the flow of the lymph is monitored using a gamma camera. Echocardiography helps in assessing the left ventricular ejection fraction or any other cardiac abnormalities like cardiac heart failure, pulmonary artery hypertension, carpulmonary or obstructive sleep apnea. This is a self-evaluating test for the patient. In this patient has to answer these questions, and it will help us predicting the uh, whether the patient has any likely chance of developing edema or not. So in the management, the first is the conservative and management. We have to restrict the fluid and salt in both kidney disease and congestive heart failure. In the chronic kidney disease, fluid and salt restriction, we have to give loop diuretics like furosemide or torsemide can be given. Congestive heart failure, beside furosemide, we can give spironolactone and ventricular remodeling drugs like beta blockers and ACE inhibitors. For chronic liver disease, we can give fluid and salt diuretic like furosemide, spironolactone, albumin infusion in refractory cases. DVT patients, they require anticoagulant therapy using low molecular weight heparin or and warfarin. And in chronic bedridden patients, the compression bandage, stockings, other compression devices, and long-term prophylactic heparin can be given. Patients with venous insufficiency can be benefited by limb elevation, high knee compression, stockings, pneumatic compression devices, skin care with topical steroids and emollients. Patients of lymphedema, they get relief with manual massaging, compression stockings, intermittent pneumatic compression. And in refractory cases, surgical procedure like bypass and debulking can be done. Patients of obstructive sleep apnea, they have to reduce their weight and they are benefited with CPAP. Hypothyroidism patient needs thyroxine replacement, and the patients of cellulitis can be relieved with limb elevation and empirical antibiotics against Staph aureus. The recommended drug dose for reducing the edema are torsemide, usual dose is 10 to 20 milligram, furosemide 40 to 240 milligram per day, bumetanide it is 1 to 5 milligram. We can give aldosterone antagonist like spironolactone 25 to 50 milligram per day if the creatinine is less than 140 micromole per liter. Epinephrine can be given 25 to 50 milligram per day. We can use thiazide or thiazide like diuretics like hydrochlorothiazide, chlorothiazide, benflumethiazide, metalazone, and non-thiazide sulfonamides can be used like indapamide. We should always look for drug interaction like we should avoid ACE inhibitors or ARB or renin inhibitor uh, combinations to as they can cause hypotension. Their combination with other diuretics like lu plus thiazide, then there can be the risk of hypovolemia, hypotension, hypokalemia, renal impairment, and we should avoid use of non-steroidal anti-inflammatory drugs with diuretics. We have to look for hypokalemia as these drugs can cause hypokalemia. ACE inhibitor cause hyperkalemia, and we have to monitor their EEGFR and other kidney parameters. So this is the Indian recommendation for management of the edema, which I have already discussed in detail in my previous slides. So, as in the initial slide, I said the patients of hypertension and type 2 diabetes who are above 50 years of age, they 41% of these patients they have pedal edema, and all patients they should help, they should get edema help, they should self evaluate them, and they should consult the doctor if they have any features of edema to rule out their cause, and so that they can be easily managed and the cardiorenal complication can be prevented. National Edema Day is observed on 25th September of every year. I hope you might have understood the causes of edema, its various presentation, what are the different causes of edema and its management. Thank you very much.